next session. So can I invite the panelists for our next session? That's Peter May and Owen Harkin and Ursula Mason to come up and join us on the stage. So you even get applause before you start here, which is great. Mind you, then what we can do is compare the applause at the end with the applause at the start. And just before I introduce the speakers, I think you'll know who they all are, but I just want to share with you a comment, and I hope that he doesn't mind that I share it with you. It's too late if he does. That I heard from Shane Devlin the other day. Now, Shane, of course, was Chief Executive of the Southern Trust and is now Chief Executive of the Integrated Care System in Bristol. And I was speaking to Shane the other day about the challenges of system working and integration in England. And what he said to me was that his experience in England had made him feel that he had not exploited the potential that existed in Northern Ireland because of the level of integration, because of the kind of capacity of change makers to get together in a room and make things happen. And he looked back and thought, why didn't I manage to achieve more given the resources, the proximity and the integration that I had in Northern? I thought it was quite an interesting point, and as I say, I hope he doesn't mind me sharing it with you. So let's get into this session, and we're going to hear first from Peter May, who, as you know, is Permanent Secretary at the Department of Health. Peter, over to you.
Okay, thanks very much. Good to see everybody here today, and thanks for the invitation. I want to start, I'm about 6 months in my job, so I've met many of you on various travels, and I want to thank you all for the time you've given me and your patience in helping to explain the intricacies of the health and social care system. And I just want to take a few minutes today to set out a few thoughts on where I think we are and what we might do to go forward. Some of the themes have already come through in one or two of the presentations already, but I'm certainly going to try not to avoid saying the same things that our minister said. I guess, if I asked the mythical man or woman from Mars, where are we today, I might get the response that I wouldn't start from here if I was you. I think we can all understand and see that the pressures on our health and social care system in all its elements are real and acute, that there are no quick fixes, and we face into a challenging winter, which, despite all of the efforts that individual agencies and the system collectively are going to make to mitigate those risks, we still face into substantial challenges. And it would be easy to get depressed. The thought that there's not going to be help coming from London or Stormont, there's not an easy answer to some of these questions. So I then asked myself, well, what can I do? And I suppose by inference, what can we do? And I want to offer three suggestions today. And the first is absolutely to focus on the things that are within our control. That is, how do we maximize what we already have? How do we improve and enhance our productivity agenda and our efficiency agenda? Not because we want to make this some sort of widget counting, but because that is the way in which we can deliver better the health and social care needs of our community today. And it's really good to see the progress that's been made in recent months in relation to some of the seeking to return to pre-COVID levels. And we now need to build on that. It's not about asking people to work harder. It's about looking at how we work. It's about identifying the things that either aren't working at all or we're not getting a sufficient bang for our buck from, and stopping those things so that we can invest the time and the energy into the things that will make the difference. The service improvements where we can learn from best practice from others, whether that be others in this room or others across health and social care. Whether it be from the technological enablers that we're developing and bringing forward, whether it be from using the skills that we have in our workforce in a smarter way and finding ways of maximizing the use of that. And if we're able to maximize what we've done, even then we won't have got all of the way. So the second question is, who can we influence? And that implies, rightly I think, that we don't necessarily have complete control of our future destiny. It's my view that we will need a sustained investment in healthcare going forward. I know from having sat looking at health from a different sector previously, there is a risk that people will see health as a bottomless pit. So that's all the more reason why we need to be able to evidence that what we do, we are making the most of what we've already got. And if we look at who we need to influence, it would be natural and I think right, we do need to influence our political classes. It's not just about money, it's also about some of the prioritization decisions that are key. Michael said we can't continue to do everything, and that's absolutely right. And it's also about taking some of those difficult decisions about how we reconfigure our services going forward. But it's not just the MLAs that we need to think about, because we need to think who influences the MLAs. And while we might think we influence them, the people who most fundamentally influence them, of course, are their constituents. That's our community, our patients. So the way in which we engage with our communities matters hugely. It's picking up perhaps on something that Matthew just said, quoting Shane Devlin. And if I may, it takes me on to the third of my thoughts, which is to think about where we need to change our own thinking and the thinking of others. And I think it feels to me like one of those areas where I would offer that we need to consider is how we see patients and communities within our system. So I think we all buy into the concept that we want the individual patient to feel a sense of agency over their own health, and we want to enable that. And we know there are some things that will make that easier going forward. So there'll be technological enablers such as the Encompass system that will give the patient pretty much real-time access to their medical records and so on. But my question is, have we put enough in place to actually fundamentally bring about that change to make the patient feel that they have that heightened sense of agency? And if we think about our communities, again, we have a vehicle coming, the Integrated Care System, the ICS, that could and should provide a real impetus in this area. But have we got the surrounding way of thinking at the moment that is going to be needed to make the community feel that they have a real say about how their health and social care services are delivered? So those are just three thoughts from me, things that I'm certainly trying to apply to myself internally. I offer them to you because if the people in this room, and indeed the many tens of thousands of people who work in health and social care, pick up some of those ideas, then we have a movement and a real prospect of making a substantial change. So thank you for listening.
Thank you, Peter. And I think it's incredibly heartening to hear that you see your task as empowering those in the system. And I think very often in the health service, I think at the NHS in England, we've kind of seen each level of the hierarchy sees its task as controlling those below them rather than empowering those and wanting to kind of invert the pyramid. So it's very powerful to hear you say that. Just one question before I turn to Owen. Because you're relatively new to the role, this is a question I can ask you now, I couldn't be able to ask you in a year's time, but what has most surprised you in terms of getting to know the way the health and care system works?
I suppose the biggest surprise for me is we call it a health and social care system, but it doesn't feel like one system all of the time. When I'm talking to people, I do find that people are very focused on what other people need to do to sort problems out and not necessarily focused enough on the part they can play and how they can influence others. So that sounds critical. It's not meant to be. I think it's a sign of a system under pressure. When people feel under pressure, they automatically think, who else could be doing better to try and help this? But it comes back to the point Shane Devlin made, which is we do have some advantages here, and one of them ought to be we know each other, we have the relationships, we ought to be able to try and think about how we try and smooth some of those systemic issues in all sorts of different ways. So perhaps that's been the biggest surprise for me.
Yeah, and I think that goes to the point, doesn't it, about the forms of leadership that we need, that Anna talked about also in her lecture. Well, thanks, Peter, and I'm sure there'll be questions for you when we get to that part of the session. So, Owen Harkin is filling in for Jennifer Welsh. So, Owen, thank you first of all for responding at the last moment. Owen's Deputy Chief Executive of the Northern Trust. So, Owen, over to you for your kind of reflections on the kind of priorities for us given the challenges we face over the next 5 years.
Thank you, Matthew, and good morning, everyone. I suppose, firstly, I'd like to take a step back and focus for a moment on the environment which we operate in. Northern Ireland is a small place, and I'll just emphasise that. We are a small place. And I stress that because we really do need to get to the point where we fully understand that. Yes, it has its disadvantages, and we've touched on some of those already this morning. But the fact is that because it is so small, it means we can get our arms around it. We should be able to get our arms around it. And indeed, we are the scale of a single ICS, back to Shane, a single ICS in the English system. So we have advantages in that. And in that, I believe, is the direction of travel for us all in health and social care. I'll come back to that in a moment. We need to operate, as Peter alluded to, as a system which is free of competition, continuing to blur the limits and the boundaries across our system. And I believe the integrated partnership boards are a real vehicle for us to deliver that further. We also need to be upfront and open and honest with ourselves and amongst ourselves, as well as with the public. That means no self-serving deals or actions done by stealth or behind closed doors, which will have a considerable impact, knock-on impact elsewhere in the system. And Anna has already described the challenges for Northern Ireland in particular, and also internationally. And I, in my day role, another role I have is National President of HFMA, and as I go around branches across England, it's very clear they're dealing with the same sorts of challenges as we currently have: flow and ED, and the flow through hospitals, and particularly out of hospitals. We are all faced with the same challenges. Ours more accentuated than most. And I suppose our particular position has recently been reflected by the Fiscal Council report, which identified the ongoing squeeze that we can expect that to continue on health and social care funding going forward, and pointed to inefficiencies, absolutely, and workforce shortages within our system, which absolutely need to be addressed. But we do need to avoid reverting to doom and gloom. That is not in our interests as leaders on health and social care across Northern Ireland, as that can permeate throughout all parts of our organisation and only adds to misery and adds to problems. We need real and genuine creative thinking going forward. Maybe we need to learn to adopt a more entrepreneurial approach. Interestingly, the Harvard Business School describes entrepreneurship as the pursuit of opportunity beyond the resources currently controlled. So I believe in these times of adversity, there are always opportunities. So what are they for us? In the brief time I have available, I'd like to touch on two. Firstly, the need for societal change, which has been mentioned already. And secondly, what the latest census results are telling us. Matthew, I've heard you talk before about the Wigan deal. And for those of us who aren't aware of it, the Wigan deal is an informal agreement between the council and everyone who works and lives in the area to create a better borough. And that has delivered some absolutely excellent outcomes. There's no reason why we, with a bit of imagination and a lot of hard work, can't arrive at a point where health and social care outcomes become a new contract with our public. And again, it goes back to Michael's point from earlier. That's where we need to go if we're going to be serious about integrated care. We need to aspire to a position where the public become our genuine partners, and where there is a gradual shift away from a belief that it is a state problem only. Recently, I've heard one of our respiratory consultants talking about the concept of health literacy, where we as health and social care organisations might better enable individuals to find, understand and use information that better inform their own health choices and actions going forward. I suppose that's the patient centricity that Anna described earlier. All of that might seem like a bit of a utopia, but I believe that is possible if we continue to break down system barriers and use data and technology to drive improved outcomes at a local level. And surely that's a goal worth pursuing. I mentioned direction of travel earlier, and the latest census results, I suppose, can help us understand and determine what needs to be done going forward. The census tells us that in the last 10 years, the population aged over 65 has increased by 24%, and that aged over 85 has increased by 25% in that short 10-year period. And if we simply pay lip service to numbers like that, all we're doing is delaying the inevitable. We need to really tackle those numbers and understand the impact they have every day on the service we provide due to complex comorbidities of health and social care and on the cost of that service. So let me give you a local example of how we see that needing careful attention as we go forward. Take the Causeway Coast and Glens area. This figures tell us that over the next 20 years, the number of births in that area are projected to fall by 11%, the biggest fall in any area in Northern Ireland. At the same time, the elderly population is expected to grow by 65%. So the population served by Causeway Hospital, for example, is changing, and we need to change with it. So what does that mean for service delivery? Looking at the situation logically, it seems to me we need to develop services focused on the particular needs of that area. In other words, we will probably be looking at developing and improving ambulatory care for the frail elderly, looking at improving and enhancing diagnostic services, extending our elective care provision, and in considering mental health requirements, we'll look at better dementia care also. That's only one example, but it shows how one particular centre might fit in very well to a regional design plan. I'll finish now, but in summary, we must lose the doom and gloom. We must search for the opportunities and ruthlessly pursue them, using using the best evidence from around the world and data, technology, digital health, and to drive transformation, efficiency consistently across the system. In doing so, we can then start to tell our story to the public so that no one can argue with it, and bring them with us. And I really believe we can start to achieve great things. Thank you.
Thanks, Owen. Owen, I spoke earlier about this challenge for leaders of addressing the urgent and pressing challenges, but also keeping in mind the need for deeper change. Do you feel that is something that you're able to do? I sometimes use the phrase split screen thinking, which is how do you look at what's in this screen, the urgent, and that screen, which is where you want to be in 5 or 10 years, and that it's really important to have both screens, because what we often do in the health and care system is we make short-term decisions which don't actually align with the long-term vision that we've got for how we want the health service to be. How possible do you think it is to be able to do that kind of split-screen thinking, and how clear do you feel is the vision of where you want to be in 5 or 10 years?
Personal view is I think that's where we've been going wrong. Shane, back to Shane's point, I think we've had numbers of reports over the years, loads of reports on all shelves all around the place. But what we've never really got on is get to what I call the punchline. So what does a redesign plan look like? What's the health service going to look like in 5 or 10 years? We need to start thinking about that and really put that on a page. As members of my trust will know, I love to see things on a page that people can understand and interpret, and therefore we can build that vision for people. I think it's been particularly challenging in the last few years with COVID, and we've been firefighting so much, and now we're trying to reset an organisation in completely different times. But absolutely, we need to take a long-term vision, and our steps in the meantime need to be about that long-term vision while addressing short-term challenges.
Great, thanks very much for that. And so, last but obviously not least, Ursula Mason, who's Chair-elect of the Royal College of GPs. Ursula, over to you.
Thank you very much, Matthew, and good morning, everyone. It's lovely to be here in person, and thank you for the opportunity to join in what I think is going to be, firstly, a bit of discussion from ourselves, but I'm hoping to take some really interesting questions from the floor later. I suppose I'm going to give you the view from general practice, and I'm going to sort of reiterate what Owen said earlier on. I mean, there's a lot of doom and gloom out there and a huge number of challenges, and I'm not going to minimise those challenges, but there is certainly a lot of positivity and innovation happening in primary care despite the challenges, and I'm going to perhaps give you a few examples of those and talk a little bit about where we are in general practice at this moment in time. I mean, I think we faced into the pandemic in a really difficult situation. We already had workforce and workload challenges at that time, and between then and now, that has been compounded. So we are trying to deal with an increasing demand on our service with a workforce shortage and also a degree of increasing difficulty to manage the patients that we have in primary care because of some of the other challenges right across the system. Because we don't work in isolation, we all work together, and I think that's a really important thing to remember. So what we find in primary care is that the fracture points and the pressure points across the system get compounded and magnified at our level. And we then also see that as an increasing difficulty for us to try and meet the needs of our patients in the communities. It was really interesting to hear Anna talk about this, and we know that there is a need to shift care into the community. Our patients need to be seen by the right person in the right place and at the right time, but most importantly, first time. And one of the things that we've seen in primary care in certain areas across Northern Ireland has been the introduction of multidisciplinary teams, and that has certainly gone some way to meeting needs of patients in our communities. But unfortunately, it isn't a widespread rollout across Northern Ireland at the moment. And for those practices that are supported by the MDTs, they are certainly being able to deliver more for their patients in the community, while those practices who have yet to have that important rollout of additional staff and skill set in primary care are struggling to meet those demands. And that's creating a huge inequity for the patients that we serve. And I think that's one thing that I would say that would make a huge difference to primary care would be to consider increasing that rollout and giving communities the access to very, very important practitioners who can both support our communities but also support our practice teams. And I don't say that lightly. I mean, I mentioned earlier that we have a workforce shortage. We have practices really struggling to survive in the current climate that we are operating in. And, you know, it'll come as no surprise to you. You see it in the newspapers frequently over the last couple of months where practices have been handing back their contracts and services are needing to be, patients need to be either redistributed to other practices, causing a knock-on effect of pressure on those, or we're having to find new contract holders. And all of that has an impact on the care that each local community can deliver, or each practice can deliver to their local community. MDTs can go some way to helping improve that, but in addition to that, we do need to see a sustained workforce strategy. We need to see an increase in our GP training numbers, and we also need to improve the recruitment and retention of GPs within our workforce at the moment. So that's a little bit of the negativity, but I'm going to really talk about, well, what can general practice do? Because we are a very flexible profession, and our practices can adapt and move to meet the needs of our local communities. And we've seen that very clearly during the pandemic. So overnight, the development of our primary care COVID centres, protecting our patients, protecting our staff, and also protecting our secondary care colleagues in terms of actually seeing and managing our patients within the community setting. That happened within the space of a few weeks, and I think it's a huge testament to our GP leaders and colleagues, and also our colleagues in our trusts in getting those up and running. And I think that's a really good example of the innovation that can happen when backs are at the wall and we need to do something to actually create safe places for our patients. I think it would be important to in terms of recognising, I suppose, the commitment of our GP workforce with regards to the vaccine rollout. 1.6 million vaccines delivered in primary care is a huge accomplishment, and again, you know, this is an opportunity for me to say, you know, primary care can deliver. It can deliver if it's resourced and empowered, and also it can do that for all of our communities. I want to touch a little bit about access and perhaps talk a little bit about I suppose digital innovation. I think we're all patients here and we all have a GP, and I probably, if I asked everyone to stand up in the room if they'd had difficulty getting through to their GP practice, I think quite a lot of people would be standing up. And we recognise that, and we understand the frustration in that. And we want to deliver good quality, safe and effective care for our communities and our patients. But access is only one little part of the system. And I would challenge the access discussion and say this is more a demand and capacity problem rather than an access problem. And in order to meet demand and capacity, we need to think about, well, do we have the workforce to deal with the demand? Or is our demand coming in a very different way? Should we be having conversations around self-care, around self-efficacy, and also, I think, very robust discussions about what it is that primary care can deliver within the current, I suppose, resource that we have. And if we can't deliver that, how do we empower primary care and GPs and their teams to do that? And I think we do need to see an increase in our workforce. I think we need to see a change in how we manage patients in the community. I think we need to talk to our partners in community pharmacy, within the community and voluntary sector, and also our colleagues in secondary care about how we manage the healthcare system and the needs-based of our patients at the point that they need care. I think there is a real need to embrace the digital transformation that is coming down the line. I think we certainly welcome the initial sort of additional resource to improve our infrastructure in primary care and around our telephony services and how we interact with our patients. But I think it's really just a stepping stone, and we need to use that, and we need to roll that out, we need to empower our practices, and we need to, I think, interface from a digital perspective with our colleagues in secondary care and elsewhere within the communities. So I'm going to finish by, I talked about the fact that, we are that foundation of healthcare in communities. And I talked about the fact that, there are the pressures that we feel are both related to, I suppose, an ageing population, multi-morbid, and the fact that there is a shift into the community. And we also see and we also feel the pressures that come from secondary care and elsewhere. And what I would call on those within a leadership perspective and have the ability to do that is to strengthen and sustain primary care. Because if you do that, then the rebuild or the move to do anything else within the system will have a really strong foundation. And when it's built, it is less likely to have those fracture points because we will be there underneath as the strong foundation that we have been, we want to be in the future, and I think we can be. So thank you. Thank you.
So, as you know, when I engage with systems in England, by far the most varied bit of the system is primary care. So, hospitals can vary from national specialist hospitals to struggling DGHs, but a hospital's a hospital's a hospital in the end. Primary care in some places is well organised, is a player at system and place level, working with other providers within systems to shape system solutions. Other places, to be frank, it's a bunch of grumpy GPs who don't like each other. And that makes a huge difference for the reasons that you've talked about, because we need primary care to be absolutely a part of this conversation. So if you think of the future of primary care, a future in which it's not really about GPs so much as about the primary care team, and GPs are managing that broader primary care team, where primary care is around population health management, not just responding to the people who ring up and walk through the door, and where primary care is a real player in terms of the development of system solutions and things like urgent emergency care pathways. Going back to the point I kind of made to Owen, to what extent do you think there's a clear account of where primary care needs to be in Northern Ireland in 5 or 10 years, a kind of North Star? And what would be resistance to that? Because one of the characteristics of GPs is their kind of fierce independence. Is it possible to articulate that vision and then through a variety of methods of nudging, bribing, whatever it might be, encouraging that kind of new model of primary care to emerge across Northern Ireland? So it's a very long question, I apologise.
That's an extremely long question, absolutely. I'll try not to answer it as a grumpy GP though. So I suppose there is difficulty there because we are interfacing with colleagues in secondary care as very different practitioners because we're all independent contractors, and there are 319 independent contractors within Northern Ireland in terms of GP practice. Certainly that was at the last count, and I'm hoping it's going to stay like that for a wee while and not fall any quicker. But with that you get, or the potential to get, 319 different viewpoints, and I think that's the challenge. But most importantly, I mean, primary care can collectively come together in a more unified voice, and we are seeing that more through our GP federations. Northern Ireland is in a very fortunate place, so every single GP practice is federated within one of the 17 federations across Northern Ireland, and through that there is an amplification of the primary care voice, but also a collectivity to it as well. And what federations are striving to do is to look at what is needed within their local community, so not just at practice level, but more at population level. So each federation is around 110,000 patients. And so again, when you see that as a collective and you use that as a model to move forward and to drive innovation and also to bring services to local communities, there is real potential. And I think, by harnessing that, and by working together within our integrated care systems, federations as the voice of primary care that's a greater amplified voice, and it is probably a greater enabler of being able to work together to meet the outcomes and the needs of our patients in those communities.
Great. NHS Confed is an organisation which represents primary care as well as the rest of the system in England. So it would be great for NICON to work with those federations and think about this future model. Now, I'm going to do something radical for the next 10 minutes, but then you will get your coffee, I promise. Right. Thank you for entering into the spirit of that so well. So I'm going to take a handful of comments or questions from the floor. You get particular credit if what your point is in terms of what the person sitting next to you said to you. So it's not your idea. You know, so this person next to me said something really fascinating. So let's get some comments, and then I'm going to bring the panel in. They'll have 90 seconds each. So as you listen to these comments, panel, just choose the one or two things. Don't try and respond to all the points. Just choose the one or two you want to respond to. And here is a hand here. Very good. And the microphone is rushing its way towards you, although it isn't. Where is it? Here. Have we only got one mic person?
No, we've three.
Okay, one there. Where's the other person? Oh, I might have to do it. Right, yes.
Andrew Dougal, Chair of the Board of the Public Health Agency. The Minister this morning mentioned productivity. In my 39 years in health, productivity hasn't been a word that's been bandied about. And discussing it with my colleague here this morning, she says, people don't maybe mention the word productivity. We talk about efficiency. We talk about we're working maximally at the minute. We're doing the best we can at the minute. But I wonder, with tight resources, with the fact that resources are not going to increase, and I've been saying this for some time, we need to have the discipline to look at things we've been doing in the past, and do we still need to do those that were there 10 years ago? And I wonder, can we ensure that the skills in improving productivity can be ingrained within professions, across professions, in general practice, in the community, and in hospitals?
Great. I think Peter may have planted that question because, yeah. Right, I can't see. Oh, yes, here. And then middle mic, just choose a couple of people because I can't really see. Oh, good.
Okay. My name is Francis Shields. I'm from the Patient and Client Council, a service user representative, and I address my remarks specifically to Peter and Owen in terms of patient involvement in the planning and delivery of services. I first started working in the NHS in the 1970s, and we had been talking then about consultation. We've changed now to participation, and we're talking about partnerships, but partnerships have to be partnerships of equals. And I think that in terms of expert people who are expert by virtue of their lived experience, when I go into rooms in the NHS now, I see people like me, retired people. Where are the younger people, and what are we actually doing in terms of inviting and making younger people feel welcome? I think there's a big issue around the language that the NHS uses and the facts around training of people who may be interested. And then there's a further barrier, which is the fact that people who engage with the NHS from a service user point of view, we don't really feel that valued, because everybody else in the room is being paid to be there, and we aren't. And for younger people particularly, who are, you know, in the situation where they have mortgages to pay and whatever, to get time off work to participate in the very important work of developing health services, I think it needs some form of payment.
Thank you. Yeah, middle of the room.
Hi, I'm a medical student. My name is Sarah, and I really agreed with what you said, Peter, about equity and efficiency in allocating financial resource. But I was wondering how we can improve the workforce's understanding and appreciation of the financial component of healthcare delivery. I don't feel personally that I feel a personal responsibility for the finances, and I don't believe that I appreciate the implications of the budget and how that's done necessarily.
That's another policy question here. The issues we want to understand how the finances work. It's all working for pieces so far this morning. Yes, here, and then someone from the back of the room, because I can't see the back of the room. So Heather, go to the back of the room and find somebody. You don't mind?
Go to the back room and find someone.
Hello, hi, my name is Jennifer Neff from Access Elemental. Just on the digital front side of things, we provide a platform that's been really well adopted across Wales and England, Greater Manchester, Scotland. And there's a lot of talk about digital and making it happen, but it's very challenging here in Northern Ireland when you have software that works and has been used by GPs in primary care and secondary care, and it brings community and voluntary sector organisations together. It's just notoriously hard to get it to be adopted here for, I don't know for what reason, but it's just flagging that, just to be able to say it's great to talk about digital, but to practically get things implemented, it's not always that straightforward, even when there's proven outcomes and outputs and impacts for the community and voluntary sector, reducing demand on all NHS services.
Great, thank you. And then Heather,
I'm trying to bully some of my colleagues. I've never heard them so quiet before. Clifford works in HSCQI, and he's bound to have something to say.
Garrett Martin from the Western Trust. I've just looked at the breaking news on the Northern Ireland BBC website saying Daisy Hill Hospital loses emergency general surgery. And I suppose for me it's about the messages of the Minister's decision. How can we work with media and other organisations in terms of actually engaging the public around the messaging of some of those and very important decisions around safety but also sustainability of services in some of our hospitals?
Great. Okay, so panel, just choose 1 or 2 points and we'll go in reverse order. So Ursula.
Okay, well, I'm going to choose productivity and also digital, and I'm going to talk a little bit about, I suppose, we feel we've been punching way above our weight in terms of productivity in primary care. And again, innovation and the change that happened around COVID. So we went from being a largely face-to-face booked appointment service to now a largely telephone first with face-to-face conversion service. And that has actually allowed us to increase our productivity. So when I talked earlier on about the fact that it's very hard to get an appointment, demand was outstripping capacity, we're actually innovating and changing what we do to try and meet those demands. So 200,000 consultations per week in general practice across Northern Ireland, with over 40% of those face-to-face. I think that's a fairly impressive figure to quote, despite the challenges, and I know that that's not meeting the demand, but it has certainly improved productivity, and that again is despite a workforce shortage and a reduction in 10% of whole-time equivalent GPs. In terms of value for money, again thinking about the cost to the system for primary care, 95% of all of a person's healthcare needs throughout their lifetime will be met in primary care, yet we receive just 8% of the budget. And in actual fact, that's very good value for money. Think about what we could do if you resourced us even a little bit more. And I'm going to put a call out for 11% and put that on record. I'm going to very briefly talk about digital. We've got a really good thing coming down the line in terms of general practice digital platform, the GPIP platforms already in practices. We're starting to use it. It's absolutely fantastic. I know Encompass is a big word, and we in GP land don't know very much about it, and it's sort of sitting outside of us. And here's the problem that you've just talked about, which is how do we integrate this all together? How do we get it all working together in a way which is actually going to improve outcomes? So it's not so much an answer to your question, but a challenge and a confirmation of what you've said about, look, how do we get this working well, and how does the digital transformation make sense across all sectors? And I'm going to stop now.
Thank you.
I'll touch on two things. First, the communication one from Garrett. Absolutely. We need, and I think that's back to my point earlier on, we need to paint the picture for the public and for our staff about where the direction of travel for services overall, that they can see the patchwork and that they're assured that there's a service there that's safe and sustainable and resilient. People have shown they're willing to travel for elective care, but we need to give them the assurance that we have the appropriate plans in place, be that ambulance support or whatever, to deal with emergency cover as well. So it's about painting that picture, from my opinion, and if that can be a reasonable picture, all the better. Can I touch on productivity as well? I think there's massive opportunities. As a Director of Finance in my main day job, there's massive opportunities for efficiency. The Fiscal Council alluded to it in their headline about how much less you could spend to deliver a basket of acute services compared to England. Now, there's always going to be some degree of diseconomy in Northern Ireland, but that's not a defence and that's not a reason to do nothing. So it's about understanding that, understanding what the offer is to the public, and deliver efficiency. There's great initiatives across the UK. I was at an event last week where Professor Tim Briggs spoke from the Getting It Right First Time initiative. He led the orthopaedics review in Northern Ireland. He's an amazing character. I think there's amazing opportunities for us to drive forward there and compare ourselves on productivity from that point of view, including such as day case to inpatient ratios, new review ratios, etc. And that's about engaging with our staff. That's touching on Sarah's point then. We have a massive task of work to make sure our staff and our clinical teams understand the finances. We're driving forward with an initiative around patient-level costing. We're significantly behind the UK in that. That's our opportunity to get really into understanding and helping our clinicians right across the full pathway from primary care through to specialist care to understand the cost of pathways and inform their decision making from that point of view.
Great, thank you, Peter. You're standing between people and coffee and the exhibition, so.
Okay, very briefly then, just to pick up on the comments that Francis from the PCC made and to recognise some of the challenges and the fact that I think it is a perennial debate about how to engage communities and how to engage patient representatives. It is really important that we do that on the basis, we are asking the questions we really are allowing people to have an influence over the solution to, rather than ones that actually there's already a preordained answer. And I think it's important that we start small and try and make things work so that people feel there is a real change, and then they're more likely to want to continue to engage. Lots of other interesting points I'd love to pick up with Sarah. I think it was about how we get clinicians more interested in finance. That would be great. And Dan West is here, who's going to grab the person who talked about the difficulties of adapting and adopting IT. So there'll be an opportunity there to, over coffee, sort some of these things out, Matthew.
Great. Well, it feels like there's a real sense of, despite the challenges, of opportunity in the room, and that, I think, bodes well for the next couple of days. You can tell that Mark is the pro and I'm the amateur because we've overrun, but could you start the next sessions at go to the next sessions at 11:40 rather than, so that's the parallel sessions will start at 11:40, and the annual HSCQI Awards will start in here at 11:40. Hold on, but before you go, can I ask you to thank our fantastic panel?